Now we're here at this point. We've talked about the filtration, we've talked about reabsorption, we've talked about secretion, and now we're kind of focusing on urine formation. The regulation of urine concentration is going to be accomplished by this countercurrent mechanism. So I'm going to talk about these two. I'm going to give you a definition, and then I'm going to show you on the image. I really just want to mention it to you so when it comes up again, I don't have any learning objective questions about it, but it might come up again if you're studying drugs and water retention and things with the kidney. So I wanted you to at least have heard the terms. I know this is a little lengthy. Don't freak out. I'm going to try to make it easier for you. So this countercurrent multiplier, they're saying that the nephron loop, even though they don't touch, they're so close together that they influence each other's exchanges. So basically, if one tube is pushing out, one side of the tube is pushing out sodium, well, water might try to go out into the interstitial fluid to balance it out, right? Water goes wherever sodium is high. So they're saying that the two tubes, two sections of the nephron loop have an influence over each other. The countercurrent exchanger is talking about the vasa recta, and I'll show you an image to remind you what that is, but the capillary bed that wraps around the nephron loop. So they're saying that this vasa recta capillary also has the ability to exchange salt or sodium chloride and water with the interstitial fluid. So both of these things together can affect the movement of solutes and water in the adrenal medulla, in the loop of Henle or the nephron loop. And this can affect urine concentration. Remember, this is the cortical nephron that we've been talking about. We said this is about 85%. Here's our peritubular capillary. So this is the one we've been talking about. When we talk about urine concentration, we're talking about the juxtamedullary nephron. So this is about 15% of all the nephrons. And you can see the vasa or vasa recta. These are the capillaries that wrap around that nephron loop. Again, these pictures look complicated, but with the countercurrent multiplier, we're saying this descending and ascending loop, the nephron loop, we're saying they're so close together that they can affect each other. So if this loop puts out sodium chloride into the interstitial fluid, is it possible that this side of the loop could put out water because water follows sodium, right? So the tubes are so close to each other that they influence each other. And then the countercurrent exchanges, remember wrapped around this is the vasa recta or vasa recta. So that capillary is wrapped around the nephron loop. So the capillary also allows fluid to be exchanged between the interstitial space and the vasa recta capillary, right? That's what capillaries do. They exchange material. So not only is the vasa recta exchanging material, but the nephron loops are so close to each other, the ascending and descending parts of the loop are so close that they can affect each other as well. So it's kind of a lot going on here. I don't expect you to understand everything because I don't understand everything. You'd have to be a nephrologist to understand everything, right? I just want you to have heard these terms. So if it comes up with any sort of, kidney function or metabolism of drugs or water retention, you've at least heard the terms. To me, this slide's pretty easy. If you are overhydrated, that means you have too much water. If you have too much water, you're going to have increased filtrate, diluted filtrate, and you're going to have lots of urine. It's going to be dilute urine. And I hate to say this, but this is kind of what we want, right? We want urine that has a lot of water in it. That's good for our kidneys. It helps flush them. We do not want to be dehydrated and have really concentrated urine. So dehydrated, that means you have low water. That means you're going to have concentrated urine. That also means ADH is going to be on. So I would make sure that I understand when ADH is on and when it's off. So if you're dehydrated, probably ADH is on, because what does ADH do? It tells your kidney tubules to reabsorb every drop of water. If you're overhydrated, your ADH is off. You've got excess water. We don't need to tell you to keep any of it. You're good. Let it go. You should see down here at the bottom what I've highlighted, that water reabsorption in the presence of ADH, 99% of all the water in the filtrate is reabsorbed. That's a pretty good percentage, right? So if ADH is on, 99% of all the water that's in your filtrate is going to be reabsorbed. The term diuretic, what is it? Anything that enhances urinary output. So if you want to think of it, things that make you pee. Alcohol. If you increase alcohol, it blocks ADH. And remember, ADH would tell you normally, if ADH is on, it tells you to reabsorb water. So if I turn it off, what happens? You have increased urine output. Or in other words, makes you want to pee. Things like caffeine, some drugs, if they inhibit sodium reabsorption. So remember, if we have sodium reabsorption, we have water reabsorption. Well, what happens if I stop the sodium reabsorption? Well, then I stop the water reabsorption. So then I have increased urine output. If we wanted to look at your kidneys and evaluate the function of your kidneys, we could do a urinalysis. So we're going to take the urine and we're going to examine it for signs of disease. We could test for illegal substances. So remember that if we're looking at renal function, what happens here? In this case, it says renal function can be assessed by measuring nitrogenous wastes in the blood. So we're saying we look at your blood and we look at if your nitrogenous wastes are high. If your nitrogenous wastes are high, that's bad. Where should they be? Where should these guys go? They should be in your urine. So something's happening in your kidneys that's not allowing you to excrete these nitrogenous waste products. I wanted to mention this clearance test. A lot of people get this confused because it looks like insulin, right? There's no S here. This is inulin. So this is a plant sugar that we can give you as a clearance test. You don't make it, you don't secrete it, you don't store it anywhere in the body, and it's not reabsorbed. So what they're saying is, whatever inulin I put in you should be exactly the same inulin that I get out. We don't make it, we don't store it, we don't reabsorb it. So if I give it to you orally, it should come out in your urine. And we can use this to determine what's your glomerular filtration rate. Is there any sort of damage to your capillary or your glomerulus? And we can use it to see if you have advanced renal disease, if it's getting worse. What should be in your urine? What should be the chemical composition? The majority of your urine should be water, about 5% solutes, and we should have some nitrogenous wastes here, some urea, some uric acid, creatinine. Remember, creatinine is from that creatinine phosphate. Uric acid is from nucleic acid breakdown, and urea is from amino acid breakdown. So the things that we can't use when we break down the protein that we eat, we're going to release those in our urine. So we can see also solutes that will be there. Specifically, we have sodium, we have calcium, we have potassium, magnesium, we have phosphates, and we have bicarbonate. So again, this should be giving you some clue about how we're going to link respiratory and urinary together, right? What should urine look like? So if it's freshly voided, just came out, the urine should be clear and it should be a pale color. Odor. Fresh urine is slightly aromatic. I like how they make it sound nice, right? But develops an ammonia odor if it's allowed to stand, and this is due to bacteria. So bacteria love urea, uric acid, the things that are in urine. So anytime urine is released, once bacteria gets to the urine, it's going to start breaking it down, and that's what starts to smell. So it's the bacterial breakdown of the urine that causes standing urine to smell bad. When it first comes out, it doesn't smell so terrible. The pH of urine, it should be slightly acidic, usually around pH 6. The ureters or ureters are going to convey urine from the kidneys to the bladder. They're also retroperitoneal. As the bladder pressure increases, the distal ends are going to close, and that prevents backflow into the kidneys. It's kind of hard to see They're saying the distal end, right? The kidney would be up here. So this would be the proximal end, and this would be the distal end. So the distal end, as the bladder expands and fills with urine, it's going to block off the distal end of the ureter so that urine cannot backflow into the kidneys. Kidney stones, I'm sure we've all heard of somebody that's had kidney stones. Calculi, renal calculi. Basically, it's crystallized either calcium or magnesium. It could be uric acid crystals. The problem or the pain comes when these really large stones block the ureter. So the ureter is not that large, and these larger crystallized stones can put pressure and cause a lot of pain in the kidneys. Usually they can do shockwave therapy, which is lithotripsy, but the stone has to be in a location that the shockwave can get to it. So sometimes you'll hear people say, oh, I have to wait for my kidney stone to get to an area to where they can actually do the lithotripsy. We have the urinary bladder. Most people just say the bladder, but if you want to say urinary bladder, that's fine. It's a muscular sac, and it's our temporary storage for urine. It is also retroperitoneal. This area, I've heard people call it different things. I've heard trigon, and I've heard trigone. So either way is fine by me. This is the triangular area. It's outlined by the opening for the ureters and the urethra, and sometimes infections persist in this area. In the male here, we can see that area, that triangular area of the bladder. Usually infections in the male are not as commonplace as females because we have a really long urethra in the male. So external bacteria has a hard time making it all the way up the urethra to set up shop in the bladder. You can see in the female here, we have a relatively short urethra, so it's much easier for bacteria to kind of get here to the triangular area to set up shop. The bladder, when it's empty, collapses. So we keep seeing these images of this nice bladder, but really this top part of the bladder would come down and it would collapse or fold on itself when it's empty. Only when it's full does it have the shape that we're seeing in a lot of these images. Next, we have the urethra, and then we're going to have sphincters. So just like we had anal sphincters, we also have urethral sphincters. And it's the same involuntary, voluntary setup. So the internal sphincters are involuntary. This is controlled by your central nervous system. Your external urethral sphincters are controlled by skeletal muscles, so these are the ones that you have control over. Here we can see the female. The internal urethral sphincters are here and here. The internals are always at the base. They're at the base of the bladder. The external urethral sphincters are here and here. So these are the ones that are controlled by the central nervous system. These are the ones that are controlled by you actively, consciously, right? So if you feel the urge to go to the bathroom, if you feel like you have to go, the central nervous system has relaxed these internal urethral sphincters, and you are contracting the external so that you don't just go all over yourself, right? When you go to the restroom, then you relax these external urethral sphincters and the urine is able to flow out. Kind of interesting, when you have surgery that they've put you under anesthesia, one of the things they want you to do before you leave the hospital is they want to make sure that you can go to the bathroom on your own, right? So one of the things that they're doing is they're testing the difference between your skeletal or voluntary nervous system and your involuntary nervous system. If all of your neurons are awake, if everybody is able to talk to the muscles appropriately, you should have no problem going to the bathroom. Here's the male. Remember the internal sphincters, internal urethral sphincters are always at the base of the bladder, and then the external urethral sphincters are a little bit farther down. One of the things that you might have seen on the model is that the bulbourethral gland sits directly on top of the external urethral sphincter. So it's kind of hard to see here, but it's this red muscle behind the gland. I mentioned this earlier, but females have a shorter urethra, so they have more urinary tract infections. Also, during intercourse, bacteria from the vagina and the external genitalia can be propelled towards the bladder. And because the urethra is so short and because of the intensity of what happens during intercourse, it's much easier to get bacteria into the bladder. Also, improper toilet habits, right? So wiping from front after defecation, so moving any sort of bacteria like E. coli, moving them forward to the vagina or the urethra could then increase these urinary tract infections. You can have inflammation in several different areas. So you can have just inflammation of the urethra, just inflammation of the bladder. You can have inflammation of the kidneys total. We already talked about these. Usually it involves some sort of painful urination or the urgency or frequency urinating more often, sometimes a fever, sometimes cloudy or blood in the urine. We have antibiotics that'll treat and cure most of these bacterial infections. So if you have any of these symptoms and you have back pain, the kidneys could be involved. Remember back pain? Maybe you remember back in 201, we talked about sometimes external nerve signals, right? External sensory nerve system and internal nerve signals kind of get crossed. They enter the same place of the spinal cord and make it to the brain. And so the brain just knows something back here hurts. I don't know if it's the muscles or if it's actually the kidneys. Micturition is urination or voiding. And I just wanted to talk about some of the events that have to occur. So you have to contract the detrusor muscles by the autonomic nervous system. You have to open the internal urethral sphincter, autonomic nervous system, and then you finally have your somatic nervous system. This is the voluntary, the one you have control over. You open the external urethral sphincter. In infants, you're going to see kind of a reflexive urination. So we really don't have control over those external sphincters yet. So we don't have conscious control. It's kind of something that has to be learned, right? So what's going to happen is as the bladder fills, it's going to activate stretch receptors. And then that is going to excite the parasympathetic neurons in the reflex center of the sacral region of the spinal cord. So we don't go all the way up to the brain, right? We're just doing a quick message goes up, hey, the bladder's full, and that sends a message back out. And this reflex is happening in the spinal cord. That reflex action causes the detrusor muscle to contract, causes the opening of the internal urethral sphincters, and then it inhibits the somatic pathway. So now the external urethral sphincter is relaxed and open. So this takes a while to learn, right? If you remember, we talked about neurons, we talked about myelination of neurons. So remember that myelination, which makes messages fast and speedy, doesn't really set in completely till you're a teenager. You don't have full myelination till you're a teenager. That's why you have the best reflexes. So this takes a while because your neurons are still being myelinated as you're an infant moving into childhood. So this is why children, it's like sometimes they're urinating and they're like, oh, I have to go. And they have no preemptive warning, right? So it's one of those things that you just have to think about, that it's not necessarily something that children can control. And so being mad is kind of silly, right? We also have urinary incontinence. It can happen just temporary. So laughing, coughing, sneezing. You can also have weakened pelvic floor muscles, and this basically, if this muscle is weak, you're not going to be able to hold the urine into the bladder, right? That external urethral sphincter is the one that you control. Well, if you can't control it, then urine is going to leak out of the bladder into the urethra. Sometimes you can have urinary retention where the bladder is unable to expel the urine. So basically you're not triggering that detrusor muscle, you're not triggering your internal sphincter, or you're having some sort of nerve problem with your external sphincter, and basically the urine is trapped in your bladder. So I kind of mentioned general anesthesia. Maybe that muscle is just not being controlled properly, right? Hypertrophy, so you can have enlarged prostate, and then that can block the urine from being expelled from the bladder. And basically they have to do a catheterization. They have to feed a tube up the urethra into the bladder and relieve or pull the urine or relieve the urine from the bladder. I'll let you guys look over the developmental aspects of the urinary system. We kind of already talked about micturition, specifically in infants, how they can't control those urethral sphincters yet. Usually infants frequently urinate. E. coli accounts for the majority of all urinary tract infections, and some childhood infections can lead to long-term renal damage. Also, some sexually transmitted diseases can inflame the urinary tract and cause pain. And the fun part, what happens as we get older? The kidneys are going to shrink, the nephrons are going to decrease in size, the tubules become less efficient, so you're not able to do reabsorption and secretion as well. Your glomerular filtration rate is half. By the time you get to 80, it's half of what it should be or what it was when you were a young adult. We could have plaque buildup in the renal arteries, and that could be part of the problem for this decreased glomerular filtration rate. The bladder can shrink. The loss of bladder tone, that detrusor muscle, can lead to frequent trips to urinate at night, or the ability to not keep the urine in the bladder and have it leak out through the urethra. Well, I hope we had fun with urinary. I'll see you guys for the next chapter. Bye.